Vicky Vella, and I work in I'm a doctor in emergency medicine. I've been doing that for many, many years, and didn't really know very much about eating disorders, to be honest, probably like an awful lot of healthcare professionals that don't work in eating disorders. But unfortunately, my daughter, one of my daughters, developed anorexia some years ago, and it was a very, very steep learning curve. And I've obviously learned an awful lot about eating disorders, and so thought that it would be good to share what I know with other doctors and other healthcare professionals who may have not had much about eating disorders in their training, which I think is quite common. I'm just going to put things into context a little bit, in that my daughter, she's going to be 21 in July, and she's been in hospital since February 2015, continuously in that time. She's not had time out of hospital. In the last couple of months, she's had the odd night out with me in a hotel and 3 separate nights at home. But apart from that, she's not been outside of hospital at all, really. And during that time, she's been in for 7 years next month, and has been on a section for most of that time, apart from the first few weeks. A section for feeding, because she started to become resistant to feeding. So for a lot of the years that she's been in hospital, she's had to be restrained for feeding, and that, you know, she's not the only one for that to have happened to. It's quite common, needing to be restrained by sometimes up to 10 staff to hold her down. Sometimes even that wasn't enough, and needing chemical restraint, so needing an IM shot of something just to try and dampen down the fight that she would give against being fed. And the reason why I say that is I think people who have never been in eating disorder units or haven't really got any idea about what goes on, it just gives you a little bit of a glimpse as to what might go on in eating disorders, and just how distressed these people are at nutrition entering their body. And what I hope that demonstrates to you, or that you'll understand, because you know, it may well be that some of you have come with very common misconceptions about eating disorders, in particular anorexia, is that nobody is going to put themselves through that just because they're vain, or just because they're choosing to diet. You know, there really is nothing glamorous and nothing enjoyable about an eating disorder. And you know, it demonstrates, I think, that this is a really, really serious illness, and demonstrates just how frightened they are of nutrition entering their body. So that's just a little bit about her, just to give you a bit of context. So, oh, hopefully is my slide going to change? We had it, oh, there we are, yeah. So why is it important about eating disorders? I'm guessing that there's quite a mix of people in the audience here. I'm not quite sure of all your backgrounds, but it's important to know about eating disorders for a number of reasons. One is that anorexia nervosa has the highest mortality rate of any psychiatric illness. The second thing is that there are many, many avoidable deaths on medical wards from anorexia. And this isn't something that is just of importance to people who want to be psychiatrists or want to be eating disorder specialists. This is relevant to whatever area of medicine or healthcare you're in, really. You come across these patients, and you know, there are many avoidable deaths on medical wards, and I will focus on one in a little while, just to illustrate how easily death can happen because people aren't educated well enough. It's important because it's very easy to do further harm to those with anorexia by just saying the wrong thing. It can send them off on a spiral downwards. It's important that we dispel some misconceptions that people have, and also, you know, I mean, I think as medical students, nursing students, probably psychiatry trainees, psychologists, you sort of develop an interest in things and think about what career you might want to follow based on what you've been taught and what you've learned. And I think if people aren't taught about eating disorders, that's not going to happen. And there is such a shortage of eating disorder professionals that, you know, anything that can sort of maybe pique the interest of somebody as a possible career has to be of benefit, I think.
Sorry,
So,
sorry, I didn't want to interrupt, but the slide's not changed from the first page yet.
oh, has it not? Oh, okay. So why is that then?
The cursor moved, but the actual slide didn't.
Okay, so was it changing before when we were doing it?
Yeah, it was working before.
Okay. Let me just see if I can do it. I'm going to reshare it. You're sharing, share. Let's see if it makes any difference. Are you on any different slide now?
Not at the moment. Perhaps if you stop sharing and then share again.
Okay, try again.
And that worked last time.
Okay. Let's try share screen. Oh, slideshow from the beginning. Have you got anything there now?
Yeah, it's on the first slide for me at the moment.
Oh, is it? Has it changed? Is it changing?
It isn't for me, but if it's changing for anyone else, if you can just put it in the chat.
Yeah, I don't know why it's not doing that, because it's changing for me.
Do you want me to try and share it on mine?
Yeah, because you've got it, haven't you?
Yeah. Sorry, everyone, just a little technical difficulty.
While you're just trying to do that, shall I stop sharing then if you're going to try and share it?
Yeah, I'll try and set up and you can keep working.
So while you're just doing that, I'm just going to show you. So this was in our local paper a few weeks ago. Concern over children's eating disorder figures. So one of the reasons why this is really important is because number of eating disorder presentations in the last year or so has really increased. And so according to this provisional data from April to October 21, which is the most recent available, showed that hospital admissions for children 17 and under was up 41%. From the period the year before, and 69% rise on pre-pandemic year of 2019. So the pandemic really has sort of made a bit of an impact on eating disorder presentations. Is that okay now?
That should be up for everyone now.
Okay.
So I'll try and follow in from what you're saying and switch over at the right time, or just let me know.
So the next slide then, which I don't know if we dare try to open the hyperlink just in case, but basically what this is this was a BBC news report. This was November 2020. There was a coroner in the east of England who did a joint inquest on 5 young women who had died on medical wards that were all avoidable deaths, and he decided to do a joint inquest and sent a report to the government. And one of these, Avril Hart, I'll be talking about in a little bit more detail in a bit. We just go on to the next slide, please. So just very briefly, I mean, I'm going to be talking mainly about anorexia because that's the thing that I know most about. There are other eating disorders, of course, and this is no way diminishing the importance of those, but it's just that it's what I know most about, and it's the one that's got the highest mortality rate. So classification of eating disorders. I mean, a lot of these you don't really need to know about, but I'm just going to mention ARFID, which is avoidant restrictive food intake disorder, which isn't really related to body image or anything like that. It's got quite a high prevalence in those with autism or on the autistic spectrum. It's often that they have really strict rules about what they can and can't eat. So they might only eat white things, or, you know, they might only eat green things, or they don't like textures in their mouths. You may or may not remember the news article of probably about 3 years ago now, of the 18-year-old boy in Bristol who was almost blind because all he would eat was crisps and Pringles. And he undoubtedly had ARFID, although a lot of people were kind of having a go at the mother on social media about not feeding her son properly. But she had asked for help time and time again and hadn't managed to get help. So that's ARFID. So anorexia nervosa is a restrictive eating disorder. Bulimia nervosa, it tends to be that they will binge and then do compensatory behaviours like purging, laxative use, etc. And binge eating disorder, they do the binging but don't do the compensatory behaviours. And I think there's a lot of people in weight loss clinics, etc., going for weight loss surgery who probably have binge eating disorder, and really all of those people should have psychological assessments and support, because it may be that actually weight loss surgery isn't the right thing for them. It might need psychotherapy rather than that. If we could just go to the next slide, please. Right, so I'm just going to read this out. This is a passage that was written by somebody who had had anorexia, called The Beautiful Life. When I lost weight, I was so happy. But when I gained even a tiny amount, all hell broke loose. It was either eat or starve, binge or purge. There is no room for happiness in an eating disorder. It robs you of all joy, and you become an automaton with no feelings. The line starts to blur between who you are as a person and who the eating disorder is. Suddenly, you're not you anymore. You're a walking, talking eating disorder. The eating disorder has invaded your mind and every part of your body. You think that you can stop any time, but that boat has long since sailed. You are no longer in control. You can't stop now. The eating disorder won't allow it. So I think this is a really good starting point to just think about what might be going on with these patients. I think the first thing to say is, I think as parents and probably, you know, partners of adults with eating disorders, etc., one of the most difficult things to deal with is the personality change in your child. My daughter was a really happy, engaging, chatty girl who, you know, wanted to be involved in everything at school and sports, and, you know, she was great. And her personality just changed into, you know, very isolated, didn't really want to talk, very miserable, you know, quite angry and aggressive towards me sometimes, which is quite common. So the personality change was quite marked. And, you know, this bit about the line starts to blur between who you are as a person and who the eating disorder is. A lot of people feel that they have become an eating disorder. You know, you're not you anymore. And one of the things that we're taught quite early on as parents or carers, and that eating disorder specialists are taught, is to see the is to externalize the eating disorder. So to see the eating disorder as something separate from the person. And I think in the context of medicine, you know, in acute hospitals and that, and people that aren't trained in eating disorders, I think a lot of sort of medics, maybe pediatricians, don't like having people with anorexia on their wards, because they see them as challenging, manipulative, really difficult patients, and probably don't like them very much. But what really you're not liking is the eating disorder. And it's really important to remember when you meet these patients that inside that person who seems, you know, aggressive and difficult is actually a really, really normal, lovely person who is powerless to behave any differently. And so you have to kind of try and see that and just remember that what you are seeing externally is the eating disorder acting out. And that there's a person in there that is desperate for you to help them. But because the eating of anorexia being as it is, they can't ask for help. They can't say, oh, yes, feed me, you know, I want food. But inside, they're really hoping that somebody's going to take control for them and is going to make them eat. It's quite a difficult concept, but it's a really important concept that you see these people as normal people. It's almost like they've been possessed, I would say. And the other thing, just this thing about you're no longer in control, I think a lot of people think that anorexia it's all about control. It's all about control. And it may be that right at the start, you know, people say, oh, I couldn't control anything else. One thing I could control is food. But actually, it's more like they are being controlled. So they're actually out of control. They're being controlled by this external being that is anorexia. Okay. Can you go on to the next slide, please? So this is something else that was written by somebody with anorexia. So it can take a long time for people with anorexia to go and get help. I think what I heard somebody say once is that the average length of time before people get help is about 5 years, because, and that's not just because of long waiting times, which of course causes a problem, but people are very reluctant to go and get help. They feel ashamed, a bit like people with domestic abuse. They feel ashamed. They don't want to admit they've got a problem, but also, what does going and asking for help mean? Well, it means weight gain, doesn't it? Because they're really asking somebody to help them. And the way to help is for them to gain weight. And so it takes quite a lot for somebody to go and ask for help. So this person had finally plucked up the courage to go and say to their doctor that they were having a problem and thought they had an eating disorder. And the doctor said, well, you don't look like you have an eating disorder. So she went home. The next line of this is, sadly, which is very common, is went home knowing that they weren't going to get help unless they looked like they had an eating disorder. This kind of thing will cause their anorexia to go into overdrive, you know, saying, well, you know, you're obviously fat, you don't look thin enough, and it just will drive their anorexia even more. But if you just think about it, if somebody came with rectal bleeding and you thought they might have a cancer, you would never say, well, yeah, you might have cancer, but actually you look fine at the moment, so we don't need to do anything. You know, you don't look like you've got cancer. So you wouldn't not treat them until they looked like they had cancer. You would get on it straight away. And just the same with this. If somebody presents themselves saying they've got an eating disorder, or they think they have, and they're asking for help, and that's the time to grab them and arrange help for them. Okay, so next slide. And what that also should tell you is that you can't tell from just looking at somebody whether or not they've got an eating disorder. You can be any weight and have anorexia. They're not all sort of emaciated, low BMI young women. You cannot tell from looking at them. It might be somebody that started off at a higher weight and is on their way down, but is still what one would consider a healthy weight. Or it may be somebody who's had anorexia before and has improved, and then is starting to relapse and is trying to nip it in the bud before they get too ill. So don't make assumptions from just looking at somebody, and to say that to somebody is really not very helpful. It's only going to make them worse. So I said I was going to just talk about Avril Hart. This is very much in the public domain, because I just think it really illustrates, for those of you who are doctors and nurses on medical wards, how easy it is for somebody to die on a medical ward. So there was a Public Health Service Ombudsman report about Avril called Ignoring the Alarms, because her father wanted investigations and what have you, because he was so so kind of shocked by what happened. So Avril, she actually died in 2012, but she was hospitalized for anorexia for a number of months when she was about 17, was discharged home, and then decided she wanted to go to university and was allowed to go to university. They said you can go providing everything's in place. So all of her details were passed to the local eating disorder team and GP for where she was going to be at university, and they were supposed to be monitoring her, which is why a lot of the report was around coordination between services. Needless to say, she wasn't monitored. So her father went to visit her at the end of November and was horrified with the amount of weight that she'd lost. So contacted the eating disorder service. They said that they'd see her the next Monday. That day came, she didn't turn up for her appointment. He went to her university room and found her in a collapsed state. So she went into the emergency department at Norwich Hospital, and on admission to A&E, she had a low temperature, low blood sugar, and a low blood pressure, which is clearly in a medical emergency. She was admitted to a medical ward, but nobody monitored her on the medical ward. She, you know, when she got there, they said, "Oh, the food arrives on that trolley over there, just go and help yourself," you know, as if she was going to do that. Nobody was monitoring what she was doing. So she deteriorated, and she was transferred to gastro ward at Addenbrooke's Hospital. She wasn't seen for quite a few hours when she arrived there, but when she was seen, there was just a cursory assessment and no plan was put in place. So she, so that evening, she became hypoglycemic. Her blood sugar was low, but she refused the treatment that was offered, and there was no capacity assessment or mental health act assessment. And overnight she became increasingly ill, and the junior doctor called the consultant on call, who didn't take any action. And the following morning she was unresponsive and had developed encephalopathy due to her hypoglycemia, and any further treatment was considered futile, and she died a few days later. Now, I mean, really, well, one, nobody should die from anorexia, and two, people shouldn't die from hypoglycemia. And unfortunately, with those deaths on medical wards, the majority of them are from hypoglycemia. Now, you know, the bit about not doing a no capacity assessment or anything, even if they had done one, you know, people who have a really low blood sugar can be quite combative, you know, can be quite irritable and won't consent to treatment. You know, they might refuse treatment because they're trying to fight you off, because that's what happens with hypoglycemia. So any other patient would have just been cannulated and given glucose, but I suspect because she had anorexia, I don't know, maybe just decided not to. So, you know, the fact that she refused it doesn't wash really with me. But as I say, many do die from hypoglycemia. We had one in Worcestershire, a completely different kind of scenario in some ways, but he eventually was found to have a really low blood sugar and could have died. And that really is lack of education. And, you know, I wouldn't even blame the staff. It's just that they haven't been educated on it. You know, very sad tale, and there's a lot of work being done with these recommendations. So can I have the next slide, please? So, I mean, these are quite old figures now. I haven't seen this updated for quite a number of years, but as per that newspaper clipping that I showed you, I suspect that the numbers are much higher now. The known numbers are much higher now. But they say about 1 in 100 young women affected by anorexia, and boys as well. Boys are allowed to have it. Men do have it. Traditionally, it was thought of as just an affliction of women. And I think that's why it's been so slow to recognise just how many men might have it, partly because of them not presenting, because they can't believe that they've got anorexia, because they think it's a women's illness, or they feel embarrassed and ashamed because they've got a women's illness, or that healthcare professionals don't recognise it in men. But the numbers are quite high. Up to 25% are boys, and I have to say that's been reflected in each of the hospitals my daughter's been at. Probably about a quarter of them have been boys. So can I have the next slide, please, Katie? So age of onset, average is around adolescence, but if you think of 16 and 17, so people always think of anorexia as being something of adolescents and teenagers. That's not far off being an adult, and there are more adults in the country with anorexia than there are teenagers. So these youngsters grow into adults with it, and they might be quite young. People might look at an 8-year-old and think, oh, they can't have anorexia, they're only 7 or 8, but they really can. So if you can't find any other reason for their weight loss, and really young people shouldn't be losing weight, you really have to have this in your differential diagnosis. And also older people as well. There are many older people who have just lived with it all their life and have never asked for help or had help. So don't rule it out. Don't just think it's an affliction of adolescence. I have the next slide, please, Katie. And it's not that rare. So the lifetime prevalence, the first bit is in the United States compared with other sort of psychiatric illnesses. Well, I'm not sure that ADHD is a psychiatric illness, but 7.7% of females have anorexia, major depressive illness 9.3%. So not that rare really. And then the bottom bit compared with medical diagnosis, this is with in adolescents, 5 times more common than type 1 diabetes and 10 times more common than inflammatory bowel disease. So it really isn't rare. Next slide, please. So the average duration of illness for anorexia is about 8 years, a little bit less for bulimia. But there are people who, it can just go on and on and on and become what they call severe and enduring anorexia nervosa. They can just have it for years and years and years, and these people still aren't beyond hope. When you see these people, they still deserve treatment, and it is still possible for them to get better, even if they've had it for 20 or 30 years. So they must be offered treatment, even if they have had it a long time. And as you can probably imagine, can have a really, really debilitating effect on their lives, and also on the carers and their family members. It's very well established that the sooner treatment starts, the more likely they are to recover. So, don't sit on people, think, oh, it's probably that, but we'll just do all these investigations first. I would say it's best to get them referred, and then while they're waiting to be seen, be doing the investigations just to rule out anything else. So of those that survive anorexia, about half will fully recover, but the rest will stay chronically ill in some way. Next slide, please. As I said at the start, it's got the highest mortality rate of any psychiatric disorder, and studies have shown that 20% will die prematurely from their illness, and that's from both medical complications and from suicide, and quite a high percentage will die from suicide, unfortunately. So there's a study in Sweden that found that about 5 to 10% will die within 10 years of onset, 15 to 20% within 20 years of onset. And if you think the onset might be when they're 12 or 13, that's young people. I don't know where I found this next line. I should have written it down, but the mortality rate associated with anorexia nervosa is 12 times higher than the death rate of all causes of death for females aged 15 to 24, which is quite a staggering statistic, really. So it's important stuff. Next slide, please. Okay. So there are many misconceptions, and I hope that I've already demonstrated to you that it's not a lifestyle choice. People aren't choosing this at all. It's an illness that happens to them. It's not caused by a desire to be slim. I kind of think of it probably as being more of a fear of fatness rather than a desire to be slim. And studies have shown that it's not caused by their mothers, which is very nice to know. But in times gone by, it was thought that mothers had a big part to play in causing the anorexia of their child, but that has been proven not to be the case. There's quite a large body of evidence now that there's a genetic basis to it, but then for that to be expressed, there's often an environmental trigger. There was a big study, which I will mention because it was quite groundbreaking, by a lady called Cynthia Bulick, who studied the entire genome of 17,000 people who had anorexia and 15,000 who hadn't. She found 8 genetic areas which were common in those who had anorexia. The thing that really, really surprised her was that 4 of those were in the same area as psychiatric illnesses, but the other 4 were in the same area as metabolic illnesses. So she said that this shouldn't really be called a psychiatric illness anymore. It should be called a psychometabolic illness. And so it may be that there is something in their metabolism. I think that maybe if they start restricting food just to go on a diet, like so many people do, or they decide to cut out fat or cut something out, then that sets off a metabolic chain of events that leads to them becoming ill. Not everybody with the gene will develop anorexia, just like not everybody that goes on a diet will, but say there's usually some environmental factor involved as well. So this is great because it means that it sort of opens the door for more research into what those metabolic factors might be, and hopefully then into some treatments, which would be great. So next slide, please. So I'm just going to talk a little bit about the anorexic voice, because I think this is something that you wouldn't necessarily get from reading books and things like that. I think it's quite a sort of unusual concept to grasp, but I already said, I've said a few times about all their anorexia, you know, won't let them do this, or externalizing the anorexia. So it's almost like they have somebody sitting on their shoulder, just talking to them, giving them a constant narrative about calories and weight and exercise, and they're fat and they're not worth anything because they're fat, and all this goes on all the time. And anorexia becomes their best friend, promising, and that's why that passage was called The Beautiful Life, promising that their life will be better, their life will be beautiful if only they would lose a bit more weight. And so it praises them for not eating and for losing weight. It makes them feel really guilty if they eat, if they sit down rather than pacing around, make them feel guilty for enjoyment. My daughter feels really guilty even if she sleeps, so she props herself up in bed to try not to sleep, because she feels like she doesn't deserve it, because that's what her anorexia is telling her. And I sort of see it as a guilt disorder, really. You know, there is fear, but I personally think it's fear of the guilt that they will feel or be made to feel if they do or don't do things that anorexia wants. And I think that because of the way my daughter talks, you know, she doesn't want to see me or have a nice time with me because she'll feel so guilty afterwards. She doesn't want to eat this because she'll feel so guilty afterwards. And I think that guilt is so overwhelming that they will do anything to avoid having to feel that overwhelming guilt. And I think that that's why some of them need restraining for feeding. You know, it's well known that sometimes if they have a tube, they're sort of okay, because they can tell their anorexia that they're not eating, somebody else is putting it down the tube, so they're not having it. but sometimes they can't deal with that. And I think that what can happen is that with all this restraint and fighting and all that is just so that they can tell their anorexia that they've done everything that they possibly could to avoid nutrition entering their body just to try and lessen that guilt a little bit. And my take on this is that that's probably what's going on. Somebody's asked me once in a talk, oh, at what point will anorexia say that they don't have to lose any more weight? But it's not like that. Anorexia won't suddenly say, oh, you're 5 stone, no, that's fine, you can put weight on again, you can stop. It will just keep on going and going, and the only thing that will satisfy anorexia is death, unfortunately. It will never give up unless the patient really kind of challenges it and fights their way out of it. Okay, next slide. So just a bit about how they might present medically. So it may be that they'll present as a known diagnosis, which is actually quite easy, because, you know, and they'll tell you that they've got anorexia. Some don't because they feel ashamed of it. But if they come and they're a known case with a complication, well, that's easy. You deal with that complication. But the ones that are sort of more, not more important, but it's really important that you might find it and expose it, because that's the only way they're going to get help. There are certain situations where you might look for it. So I already said earlier that quite a high number will die from suicide, unfortunately. So really anybody that presents with an overdose or deliberate self-harm should have questions about their eating. You know, half those who deliberately self-harm have eating problems. And if you don't ask and you miss it, then, you know, that's a bit of a disservice to that patient. If you do ask and you pick it up, and they say, well, yes, actually, that's what this is about, which does happen. I think that, personally, I think that you should be the person to refer them to eating disorder services. The other thing I would say is that if you're seeing somebody with an overdose or self-harm, don't think, oh, it's okay, I don't need to ask, because the mental health liaison staff will ask, but they might not. I was really shocked to find that in RMN training, in many places, they have no training on eating disorders, and those people then become mental health liaison staff and they don't really get it. So don't always assume that the next person knows what they're doing. The next person will ask, the next person will refer them. You ask. If you find it, you refer them, because, say, the next person might not have had any training, be that a medical consultant, be that a GP, be that a psychiatrist. So if you unearth it, then you refer them. So DKA, diabetic ketoacidosis, there's quite a high number. There was a study in Canada trying to find out how common it was amongst type 1 diabetics to leave out their insulin in order to lose weight. And so they did the study in Canada, and 16 to 25-year-old females with type 1 diabetes, 70% of them admitted to omitting insulin in order to lose weight. That's a really high proportion. Not all of them will have an eating disorder, but some of them will, and that's quite a precarious situation, as I'm sure that most of you can appreciate. And I know that I will have seen patients in the past before I knew any of this stuff. You know, I can remember seeing young people coming in with DKA and looking for a reason why they might have DKA, and they just said, oh, I forgot to take my insulin or so. And I because I didn't know this, I wouldn't have pressed them on that. But, you know, I wonder if I might have missed some of these. So it's really important, if you've got people with DKA and you haven't got a good reason for them, or they say they didn't take their insulin, to just question them a little bit about that, because it can be quite hidden. And as I say, it's quite a precarious metabolic situation, and these people do need help. collapses and vasovagals, you know, a number of times in A&E we've had teenagers that come in who have fainted, and you know, you think, oh, why did the school bring them in? They've only fainted. But some of those might have an eating disorder, and you know, in the past I used to just say, oh, did you have breakfast? No, well, just make sure you do in future, without really probing, but have unearthed a few who actually have got an eating disorder, and this is how it's presenting. And the thing is, if they get to the point that they're fainting, then they're actually starting to become medically unstable and need a proper assessment for their physical health. So don't just disregard vasovagals as just teenage faints. I think it's important to ask them about it. And sometimes they've got other illnesses, they'll just hide it, you know, I've lost weight because of my Crohn's disease, or I've fainted because of my brain tumor. I'm saying that because we've had those in our department. So, you know, they may well try and hide it because they know that exposing it potentially means you're referring them for treatment, which means weight gain. So if I can have the next slide, please. So just a bit about MARSiPAN. I don't know how many of you, I did this talk for foundation doctors this afternoon, and none of them had heard of MARSiPAN. MARSiPAN is MARSiPAN Guidelines, management of the really sick patient with anorexia nervosa. And the first report came about because Paul Robinson, an eating disorder specialist in London, was getting lots of sort of communications from people nationwide, doctors nationwide, about young people dying on medical wards. And most of them, actually, when you look at the cases, were from hypoglycemia. And he felt that there needed to be some kind of guidance for non-eating disorder specialists around how to manage sick patients with anorexia. So there's also a junior one, the current guidelines for 2014, but they're just being updated, and hopefully sometime in the next couple of months the new guidelines will be out. They're very comprehensive, and the new guidelines are really good, actually, and they're not going to be called MARSiPAN, because a lot of people with eating disorders don't like that name, which is quite understandable. But still, if you Google MARSiPAN, it will automatically take you to the new guidelines. So it's important for you to have heard of these. If we just go to the next slide. And it's quite wide ranging, you know, it covers a lot of stuff, but I think for people in emergency settings, and also GPs will use MARSiPAN to assess physical health and eating disorder. Community teams will use MARSiPAN to assess if the patient actually is so ill that they need admitting to an acute medical or paediatric ward. They're physically unstable. So these are high-risk features. A lot of people ask me, or how many of these do you need to say that they need to come into hospital? And there isn't really a set number. You do get a bit of a gut feeling, but you know, clearly if somebody's heart rate is below 40, or they've got other ECG abnormalities or electrolyte abnormalities, they would need to come in, or they're collapsing or that kind of thing. But actually eating disorder specialists say that if somebody's got one of these, then they should be admitted to then be assessed properly by an eating disorder specialist, because even if they've got one of these, if it's an eating disorder specialist, they can say, oh, well, it's okay, yeah, you've got that today, but I'll see you back in a couple of days in clinic. But if they just come to A&E or something, you can't do that. So it's better to just admit them and get them properly assessed and start feeding them on a ward. We can just have the next slide. So the next slide is the MARSiPAN checklist, okay, and you can see that it's got all those high-risk features there. But this is a really good tool to use. If I have somebody and I'm thinking, right, I need to see if they need admitting or how, you know, how much risk they're at, I just Google MARSiPAN checklist, print this off, and then it just tells you what to do, and just sort of takes you through the investigations you need to do. You need to consider mental health act assessments, etc., and features that increase risk. The other reason that I think this is really, really good is that most doctors haven't heard of MARSiPAN. in my experience, most medical registrars and even some paediatricians are really, really reluctant to admit people with anorexia, probably for the reasons that I've said before, is that they just find them really challenging and end up with them being stuck on the ward for weeks on end. And you know, many haven't heard of MARSiPAN, and I think if you can print something off like this, fill it in and present it to them and say, look, this patient with anorexia, the guidelines are telling us that they've got high risk features. They can't really argue with that. Well, they'll still try, but they can't really argue with that. You've got something tangible to show them that you've done a proper assessment, and this is what the recognized guidelines advise you to do. Okay, so it's really useful for that reason as well. Can I have the next slide, please? So just a few things about how to talk to them, and a few little snippets here. So telling somebody with anorexia to just eat, unfortunately, happens a lot, but isn't going to work. Okay, if they could just eat, then they wouldn't have anorexia, would they? Telling parents to, oh, well, just go away and try and feed them, and then we'll see them again in a month. The parent wouldn't have brought their child if they were just able to feed them. The parent has brought them because they're at their wits' end and they've stopped being able to feed them. So that doesn't help. They need to be referred and they need help. Regard it as a mental illness rather than a choice. I think I said before, you know, that you can be of normal weight. So don't disregard somebody, you know, say, oh, you can't possibly have anorexia, because they might even look overweight and they can still have anorexia. Some things about what to say and what not to say, and I said earlier about it's quite easy to cause more harm. You know, obviously in that first thing that I showed you, the doctor saying you don't look like you have anorexia, it's just, oh well, yeah, you're fat, you're fat, you're fat, you're not thin enough. Don't praise people for getting better and putting on weight, because that means they're fat. Don't tell somebody, oh, you look really healthy, that means they're fat. You know, if you need to do a greeting for somebody, I would just say it's really nice to see you, rather than, oh, you look well. And just something that happened to my daughter, just as a little bit of an illustration, is that when she was first assessed for anorexia by the consultant psychiatrist, who wasn't an eating disorder specialist, I hasten to add, did all the assessments and called us back into the room, and he said to her, right then, Catherine, we can we make a diagnosis of anorexia nervosa. One of the criteria for that diagnosis is that you have to be 85% or below of your ideal weight for height, and you are 85%. So, you know, we can make that diagnosis. So we left after this plan was put in place. The very, very first thing that she said to me when we got out of that room was, there we are, I'm a fat anorexic. Okay, so you have to be so careful about what you say, because that will have been her anorexia saying to her, well, you're only just there, you know, you're a fat anorexic, aren't you? You've got to lose more weight, you've got to lose more weight. And after that, we went home. I think she had one more night on the acute paediatric ward. We went home, nothing passed her lips for 2 weeks, because I think that really, really sent her wild. So you do have to be really, really careful about what you say. If I can just have the next slide, please. Just very briefly, a bit about compulsory admission. People with anorexia are really expert negotiators, and they will try and do anything to not stay in hospital. You know, even if they're really, really, really unwell, physically unwell, they will be terrified. They won't want to come into hospital. Their eating disorder, their anorexia will be saying to them, don't you get admitted to hospital, because admission to hospital, they're going to feed you and then you're going to put on weight, and you know, you can't be doing that. So they will do anything, they'll say anything to get out of hospital. Oh, yeah, well, I'll eat, I promise I'll eat when I get home, and all this kind of thing. But if they are physically unwell, you've got to treat what's in front of you. You've got to try and look at what's in front of you. Think this person is really physically unwell. and try and think all this stuff that they're saying, that's their eating disorder talking. That person in there is really ill and needs me to take control for them. There's somebody I know very well who's actually an emergency physician who had anorexia. And I asked her one day, I said, you know, when you used to negotiate your way out of things and that sort of thing, I said, what did you think inside? And she said, I used to just think, they've listened to my anorexia, they're not treating me. And she used to be disappointed that people hadn't taken control. So you need to just remember that these people aren't going to ask for treatment because they'll feel really guilty about it. You know, somehow they're not allowed to say, no, do take me into hospital and feed me. They can't do that because it's just too guilty. Too much, yeah, it's too much guilt. So you may need to consider compulsory admission. Doing a mental capacity assessment isn't really that useful because they're all just going to pass it. Doesn't really help. The thing that will really help is getting a mental health act assessment. So if you've got somebody that physically you're worried about and they want to leave, you're much better getting a mental health act assessment done, and then that will allow them then to be put on a section and admitted for feeding. I haven't got the MARSiPAN cases to hand, but if you look at the MARSiPAN guidelines, they've just got précis of the cases that were sent to Paul Robinson that made him do the MARSiPAN guidelines in the first place. Most of them, as I said, are around hypoglycemia. A little bit about carers. Carers, it's an awful illness. I think it's probably one of the, I can imagine it's one of the worst illnesses to see your child go through for a number of reasons. One is you don't get much help. It's very, very scary. You just think your child is fading away and dying. There's very little support available. Waiting lists for treatment are very long, but also you have a child that hates you in general. And because the reason for that being that you are trying to treat them, you're trying to make them better, you're trying to feed them, and their anorexia just gets really, really angry with you. So many parents are beaten up, shouted at, screamed at, you know, they don't want to be with them. And that's really, really sad and really, really heartbreaking for a parent. You know, I can't think that there are any other illnesses where a child wouldn't want the parent helping them to get better. And a lot of parents are very isolated. They, you know, the stigma attached to it, they don't want to tell that many people, so they can become very isolated themselves and don't really get a break from it. You know, they can just spend the whole day trying to feed their child. They might have to give up work. Then there's financial issues. So carers really, really do need a lot of support that isn't forthcoming, to be honest with you. But the other thing is that carers tend to learn quite a lot about it, and it's quite a scary time for carers taking, you know, parents taking their young person into A&E or something, because they know that the chances are the doctor that they see is not going to know a lot about eating disorders. They might say the wrong thing, they might not take them seriously. So, you know, it's very, very difficult. And the carers, I think doctors have to be real, and nurses have to accept that the carers will know an awful lot more about it than they do, and take on board what the parents' concerns are. As far as treatments are concerned, unfortunately, there is no wonder drug that will treat it. It's obviously feeding is the most important thing. You're not going to get a malnourished brain engaging in in-depth psychotherapy. So feeding, getting them physically better and getting their brain nourished is really the starting point. And then once they start to be better nourished, then the other therapies would start. You know, and some people are turned around fairly quickly, I guess, if it's caught early, and other people take a long time, and some people don't ever fully recover from it, as I've said. But hopefully more research will be forthcoming with treatments. The last little bit that says Twitter feed, I think because people really aren't treated very well because of people misunderstanding it. And I did ask on Twitter one day what people with eating disorders would like doctors to know, or emergency staff to know and understand. And I got so many replies. I'm not doing it on purpose. It's not as easy as just eat. If you must weigh us, please do it discreetly. Try not to be patronizing about it, and give us an option to be blind weighed or weighed backwards. Other people on the weighing thing have obviously had times when they've been blind weighed, but then the nurse has shouted it to the nurse down the corridor. So I always say, you know, if you don't want to know your weight, we can weigh you backwards. I'll write it in the notes somewhere where you're not going to catch sight of it, and I'm not going to say it out loud. And that just shows that you've got some understanding. Never make jokes about wishing you could just starve yourself for a few days, that you could have anorexia for a week or two to lose weight in the earshot of somebody with an eating disorder or at all. It's not a phase or a fashion accessory. When I had low sugars, me saying I'd rather end up in a coma than eat a biscuit, because I was absolutely terrified and scared and generally didn't have the capacity to think rationally. So don't look at me like I'm a weirdo and send me home. Don't laugh because they're asking how many calories are in a saline drip. Laughing at people thinking water's going to make them fat. So really the upshot of that is just validate their illness, show concern, show understanding, and as somebody wrote here, just be passionate. We're absolutely terrified. So I think there might just be one more slide with some resources on, and then yes, so I've just got a few things here that you might be interested in. So obviously there's the MARSiPAN Guidelines, which isn't a huge thing to read, and you can pick out the bits that are relevant to you. But of course there will be the new fantastic ones coming out soon. This is quite a good website, it has quite a lot of information on it. Nice, there are nice guidelines, although a lot of those guidelines just say refer to the MARSiPAN Guidelines. So BEAT is the main charity for eating disorders, and there's loads of information on there about eating disorders. And ABC, Anorexia Bulimia Care, is a smaller charity and also has lots of information. And both of these have helplines for patients, for carers, for siblings, so anybody can phone up and get advice from them. And in fact, if I see any patients with a new diagnosis, you know, the parents just don't know what, you know, they're all in a tears, they don't know what's going on. I usually write down a few of these for them, take away, so that they've got something that they can go and look up that's reliable. This one here, Freddie Flintoff, I don't know if any of you watched it, Freddie Flintoff, Living with Bulimia. It's an hour long, and it was a really good insight into a male with an eating disorder and all the sort of difficulties that he had with that. And then this one I just think is absolutely fantastic, and I think every parent and everybody that's kind of new to eating disorders as a professional is worth having a look at. It's on BBC iPlayer, called Overshadowed, and it's a series of small little films, each one's probably about 10 or 15 minutes long, following the course of a lovely young vivacious teenager who decides to do a health blog showing what happens to her in her descent into severe anorexia. But what is so clever about it is that they have another actress dressed in black standing behind her, talking to her with all the lies that anorexia tells somebody, so that you can see why she's then behaving as she is towards her parents, why she's over-exercising, why she's doing this, why she's doing that. And it's just a really, really clever way of demonstrating the anorexic voice. So if you feel that you want to learn a little bit more about that, I can't recommend that highly enough. It's brilliant. So I think I've sort of come to the end of my slides. I can talk for hours on this, so there's lots of things that I probably haven't said that I could say, but I think it's 7:30 now, so I don't know if there are questions or...
Yeah, so just a massive thank you for that talk again. It was a really informative and unique insight as well. I think a lot of stuff that you definitely can't get from textbooks and just be really useful for everyone.
Yeah, I mean, I always try and avoid, I never do about signs and symptoms of it and things like that, because you can just go look those up in books. That's easy. It's the other stuff really that you'll only get from people that have got experience of it, really.
Yeah, definitely. So if anyone has any questions, you can pop them in the chat. We've had a few, so I'll just ask a couple of them whilst we've got time. So first of all, what do you think could be an effective way to tackle the current crisis in the eating disorder services? That's a big question. Yeah.
It's just an absolute nightmare, isn't it? It really is a nightmare. There's a real crisis, and I mean, this is so bad now that I know of people, I've spoken to people who are tube feeding their children at home, which is just shocking, because there just isn't an eating disorder bed for them. Yeah, I just can't imagine what that's like, especially if the child then starts refusing to have the tube. Then it's just an absolute nightmare. I think an effective way to tackle it would, one, be more health professionals deciding to specialise in eating disorders. I think there's a huge deficit in eating disorder consultants. Obviously that isn't going to be something that's going to change in the next month or so, but the more people that learn about it might just develop an interest in it and think, oh, that's something I'd really like to do or have some experience of. So one is the workforce, and two is just it's always going to be money, isn't it? There are lots of places, even like where I am here in Worcester, we don't have an eating disorder specialist consultant. The adult service doesn't, and it's just a small team of nurses, and I think they're expanding a little bit now. And unfortunately, what happens, you'd like everybody, as I said, people should just be referred. It needs to be caught early, but because there's such a backlog, unfortunately, because of their limited capacity, they have to see the ones that are iller first. And so somebody with a BMI of 14 is going to be seen before somebody with a BMI of 20, even though they might have the same psychological things going on. So it is really, really difficult, but I think a lot of it is we need more people to go into eating disorder, become eating disorder professionals, whether that's as nurses, psychologists, gastroenterology, doctors, because obviously they have them on the wards, paediatricians, there's a lot of people that could do with just knowing a bit more about it and perhaps finding ways of reducing people's chances of admission or need for admission, developing new ways, which some places are doing.
Yeah, definitely. It's definitely a big team effort.
Yeah.
Another question, what is the best way of supporting our patients whilst they wait a long time to be assessed?
So I'm presuming that we're talking about patients in general practice. Would we be here? That would seem the most likely thing, because it would be GPs that would be left to support patients while they're waiting for assessment. Because if they're on medical wards or pediatric wards, then they're being looked after, aren't they? So I think that there is a big debate about who should be monitoring eating disorder patients. First of all, should it be the eating disorder services that are doing all their observations and all that regularly, or should it be the GPs? That's the first thing to say. And GPs think it should be eating disorder services, and they think the GPs should have a part to play. I think if you're a GP or a GP nurse or something, and you've got patients that you're waiting for them to be seen, I think you should be seeing them very regularly, checking their bloods, checking in on them, sort of monitoring their weight, etc., and just being really caring and compassionate, and they are deserving of help and needing help. You know, because any that you suggest that they're, as I said, that they're not ill enough, or if you're dismissive of them, you'll just lose them and they won't come back and they'll just get worse. So yeah, there's blood monitoring, weight monitoring, and also phone calls to the parents or carers are probably quite a nice thing to do. When my daughter was first unwell, the GP phoned me, you know, every week for the first while, just to make sure that I was okay and that we were managing things okay. I hope that answered your question. I've done that from a GP angle. Hopefully it did.
Yeah, I'm sure it would have done. I think, as you say, the influence on carers as well is really important to take account of. So I think we'll have to end the questions there, just so we don't keep you all evening. But I'd just like to say a massive thank you again, and also thank you to everyone for joining us.